Now we're heading to acute kidney injury. Acute kidney injury is a very serious situation, and we will talk about different causes. But acute kidney injury means that the function is decreased. It means that BUN and creatinine are increasing. So it means acute azotemia. Okay, so azotemia. So acute increase of these two substances. That's the only thing we care about. And the majority of the problem is in tubules or tubulo, and let's say some of the interstitial causes as well. But mainly you should imagine epithelial cells as they are getting ischemic and necrotic. But as I told you, in few cases, it could be also due to serious inflammation of the glomerulus. So in some cases of acute glomerulonephritis, suddenly you're going to have azotemia. But for the rest of the talk, we're going to focus on tubules, and there I will mention one problem which concerns interstitium. But rest of the problems, I mean, if the causes are within the kidneys, we're focusing on tubules because that's the most common cause. Okay, and I'm going to draw something again, which you know. It's the renal papilla, and I'm going to remind you that a bit. This is a glomerulus over here and over here, and as we know, this is the efferent artery, and over here we have a tubule that can like twist and goes down and up, touches it, and then enters the collecting ducts. Okay, you got urine over here, and over here the artery twists around the tubule, of course. And of course here we have a vein which collects that out. So that's renal papilla and one of the nephrons over there. And what I want to stress over here is this border, which is the cortex and medulla border. I will rather put it here. And this is the corticomedullary junction. And this is a very important place, okay? And I'll come back to it very soon. So let's get to acute azotemia, or in other words, acute kidney injury in most of the cases. So it means there are different causes why the BUN and creatinine, why they go up suddenly. And the thing is that they don't have to go up only because of the problem within the kidneys, but also because there's a decreased perfusion of the kidneys, so the kidneys don't have enough of time. Okay, there's still someone coming. So there's cortex, medulla, and corticomedullary junction. And what I want to say is, watch out. Azotemia, increased azotemia means the kidneys are not able to clear the blood, but the cause doesn't have to be necessarily within the kidneys. It can be because of the flow to the kidneys of the blood is so slow that kidneys, although they're functioning fine and they're feeling fine, they just don't have enough of time because of there's not a proper flow to clear the blood. So that's why creatinine can start to rise and urea as well. And it's a problem of something else than the kidneys itself. It's a problem of the circulatory system. And this is the first cause, and it's called prerenal azotemia. So prerenal azotemia is a problem of the pressure, that's one, with which the blood flows into the kidneys. So if I have prerenal azotemia, or in other words, prerenal acute kidney injury, the reason why the kidneys are not able to get rid of creatinine and urea is just because of the decreased pressure they're getting. And the cells in the kidneys are feeling fine. The epithelial cells are feeling fine. They are still working, but just are not able to catch up with the clearance because of the decreased flow. And that's one of the causes of, and so it's called prerenal azotemia. Then you have another problem, and this problem is obstruction. So there could be a stone, for example, but watch out in both ureters. There has to be one stone in one ureter and the other one in another one, or in urethra. And in this case, the outflow is not working, okay? And again, the parenchyma, at least at the beginning, is totally fine of the kidneys. But you are just not able to filter through the glomerulus because it's blocked over there. And this cause is called postrenal, okay? So the problem is postrenal. So this would be 3, postrenal. So postrenal, so that there's some obstruction, and that's why the pressure is building backwards. And because there is not enough of pressure gradient in the glomerulus, you're not able to filter. But the parenchyma of the kidneys is, at least at the beginning, fine. It's working. And also in both of these cases, in case you implant the kidneys into the healthy person with normal pressure and with normal outflow, they will work. So that's prerenal and postrenal. But, and especially both of these causes, prerenal and postrenal, they can also turn into intrarenal, okay? And typically more we talk about the prerenal cause, which means if there is a decreased flow of the blood to the kidneys, it's causing also ischemia. And if the ischemia is too serious, now you will start to fail within the kidney parenchyma, and you call it intrarenal or intrinsic azotemia, okay? So I will still put here azotemia. But these two have nothing directly to do with the kidneys itself. The problem is elsewhere. But in case of, what color? Blue. In case of kidney parenchyma, that's the intrarenal or intrinsic azotemia. Okay? So that's the intrinsic azotemia. So, first I will talk about prerenal, then postrenal, and then I'll give you direct examples of the intrarenal one. And those are the main ones. But still, if we talk about intrarenal intrinsic azotemia, you should understand that most of it is about some kind of combination of ischemia and a toxin. Toxin, something that is toxic for the kidneys. Either it's endogenic or exogenic, it's a drug, it could be whatever. And most of it, again, we will talk about tubular necrosis at the end. So it's called acute tubular necrosis. This is a very important term for you, okay? But there is also one which is where we rather focus on interstitium, and it's called acute interstitial nephritis. But I'll tell you more later, okay? But now I will jump to prerenal causes. And what are the prerenal? So if it's prerenal, it means anytime there's hypovolemia. So in case I'm going to have hypovolemia, or hypotension if you want, hypotension, then of course any of these can lead to prerenal azotemia, just because of the decreased flow to the kidneys. So, and what are they? Well, of course, all kinds of shock, hypovolemic, septic, etc. Okay, but it doesn't have to be so severe as shock. You can just take diuretics and you just slightly decrease the pressure, and already there could be some rise of creatinine because you're just not clearing the blood with enough of speed. And then, of course, remember maybe pancreatitis. And also remember any cause when there is a decreased oncotic pressure again. So there could be a liver disease, cirrhosis, etc., or malabsorption, okay? Although we're going to talk about hepatorenal syndrome, which you rather put under the intrinsic or intrarenal causes, okay? But over here, in general, if you have decreased oncotic pressure, you don't have to filter so fast enough, and that's why you're going to have prerenal azotemia. And also, which is very rare, but you can have bilateral occlusion or partial occlusion of renal arteries, okay? And in this case, you're going to decrease pressure in both of the kidneys, and that's why first you're going to have prerenal azotemia. Yeah. Why I'm telling you this, stressing you this? Well, the reason is you should always remember that if your kidneys are sort of healthy, you are fine with 1/3 of one kidney. So that's why if there is an occlusion or decreased pressure in one of the kidneys and the other one is working fine, you should be totally fine and there will be no azotemia because the one kidney can keep up with this. That's why you can also give a kidney for transplantation. There is a high redundancy. So always think of both kidneys are having decreased pressure. That's why hypovolemia, that's why shock, that's why diuretics. Of course, yeah, we can put congestive heart failure, yeah. If the heart is not able to pump enough and that the cardiac output decreases, well, you're going to have prerenal azotemia as well. And why is prerenal so important? Well, I said it already, because there are two aspects. One is that the blood has to be filtered in certain speed. If it's too slow filtration because of the low pressure or slow flow, well, although the kidneys would be functioning fine, they cannot make it in 1 hour or 1 day, or it doesn't matter, in time. But the other aspect is the kidneys, they need the blood to live. And when the pressure is so much decreased to a point where basically kidneys stop caring about the filtration, but they more start to care about themselves, the cells, and they're not getting enough of energy, well, they will start to get ischemic. And when this happens, all the prerenal azotemias will transform into intrarenal azotemias. So when the pressure is just a bit low, it's not ischemia, which is happening in the kidneys, it's just the slower function or lower function. But if it gets below certain threshold, now they're getting ischemic and it just transforms into intrarenal failure or intrarenal acute kidney injury or intrarenal azotemia, as you want. And that's crucial because you as a clinician, you need to find out, you need to know if this is still okay. And basically, if I give him some fluids, I can save the kidneys and it's fine. Or if it's already fighting for the kidneys themselves, like it's already started, the ischemia started, okay? So that's very important to know. Good. And after this, I'll tell you some markers, blood markers. After this slide, I'll tell you some blood markers and things to look for in blood and urea with which you can pretty much say, hey, it's still prerenal, or, oh, oops, it already turned into intrarenal. But now I will stick to the causes. So these were the prerenal causes, prerenal azotemia. And then you have post-renal azotemia. And post-renal means there's a blockage. So what could that be? Well, it's a stone, but in both ureters again. It has to be in both ureters, because if there's one ureter, again, the other kidney will work fine. So no azotemia will appear. So again, we have to block both kidneys. By the way, what do you call if one kidney, what will happen if one kidney is blocked? If there's a stone in one ureter, you call it hydronephrosis. You will see it on CT or sono. One of the kidneys is going to be enlarged inside. You'll see ureters will be enlarged. That's called hydronephrosis. But that's just a detour. Okay, so remember stones. Or there could be a stone, one stone in urethra. And of course, this blocks both of the ureters then. So or urethra blockage, whatever. Well, but we got other things. Okay, so men, what men will have? Well, they will have prostate. Prostate hypertrophy or tumor, doesn't matter. Cancer, okay, there's a blockage. Women will have what? This is a very awful cancer, cervical cancer. And when this will spread in the pelvis, of course, it will block everything. And basically, this is one of the causes why they die. They die on kidney failure, typically, these women. And then don't forget, if there is the ureters, they go through retroperitoneum. So retroperitoneal fibrosis. This is due to chemotherapy for whatever the cause is, whatever tumor you have, or irradiation. If there's a tumor, they irradiate. If they irradiate that space, they can cause fibrosis, and this just constricts the outflow. This constricts the ureters. And last one, don't forget, and there are many other causes, but I'm sure you can figure out neurogenic urinary bladder. This is typical after spinal cord injuries. Okay, so you are not able to urinate. You keep the urine inside of you, and that's how you block the flow, and that's why the azotemia appears. Again, if the blockage is too much, the pressure in the kidneys increases too much, the pressure in the nephrons increases too much, later and sooner it will turn into intrarenal failure as well. Important comment, with the postrenal, it depends what type of problem it is. If it's going to be fibrosis, well, that's very hard for you. But if it's going to be, let's say, neurogenic bladder, well, you just put a Foley catheter inside the person and that's solved, because you suddenly, there's burst of urine out, and that's how you cure, at least temporarily, the postrenal azotemia. The same as with prerenal. Yeah, if you give infusion because it was bleeding or whatever, and if you normalize the pressure, yeah, you will again prevent the intrarenal transformation. Okay? So with the prerenal, you can sort of deal with yourself, depends what type it is. Postrenal, sometimes if it's a stone, no, you need to call urologist to get it out. Or if it's a serious, prostate tumor and, you're not able to. So basically, in postrenal, that's the business for the urologists a lot. Well, and now we're turning into intrarenal, and guess what? Well, that's the case for nephrologists, okay? All of them, basically. Okay, because they have to wisely decide the strategy, if it's for dialysis already or not, etc., etc., okay? So in this case, if someone fails intrarenal, don't wait and call a nephrologist. So, and we're getting to intrarenal causes. So both of the prerenal and postrenal can turn into intrarenal causes. But of course, I'm going to now tell you the toxins and the toxic environment that directly causes intrarenal failure or intrarenal azotemia. And still with the percentages, remember, these two azothemias, they cause like 80% of the causes. And yeah, if there are still pre-renal, post-renal, that's fine. Depends on the cause. If it's congestive heart failure, that's bad. But if he's bleeding and you normalize, it's fine. You solve the problem. Okay. Well, in cases of intrarenal, they have 20%, but of course, in most of them, it's very serious because it could be really lethal toxin or too much of the toxin, etc., and combinations. Okay. But again, what you should understand is always ischemia is one of the factors and toxin is the other one. So, for example, you can have hypovolemia, it's prerenal, and now the patient eats a toxin like non-steroidals, or they do a contrast CT scan, and this right away kills the kidneys. So remember, ischemic kidneys, that's a ischemic environment which just easily makes the kidneys slip into the immediate failure. And what are the toxins? So ischemia in general, always think of ischemia and decreased pressure and flow to the kidneys. It's serious. The ischemia can cause it right away, totally alone, because it's like if you stop the blood to the kidneys, they will die. And you can speed it up also even with the toxin, okay? And what are the toxins? So there are exotoxins. So, and this is my division, okay? So watch out. But exotoxins, I mean, you ingest them, okay? And those are all the very toxic drugs that will cause not only this, but kidneys are very vulnerable. So amphotericin, toxic to everything and of course to kidneys. Gentamicin, cisplatin, okay? As I told you, contrast. Contrast is very serious. In case of amphotericin, gentamicin, cisplatin, it takes a while before you fail. So you take them for several days and then you fail. Then you have acute tubular necrosis. But with contrast, it can be like second day. It's very dangerous. It can be very instant. So contrast induced, please remember, contrast is toxic directly to the epithelia, but plus there is this effect of vasoconstriction of afferent arteries. Okay, so it doubles. It causes ischemia and also toxicity to the epithelia. And then you have your beloved ethylene glycol. Very toxic. Basically, paracetamol, if you want to kill your liver, take paracetamol. Take 20 tablets, your liver will die and you will die. No way back. And with ethylene glycol, fortunately, we have dialysis, so we can save you and you can wait for transplantation. But ethylene glycol is a parallel to paracetamol for liver. Ethylene glycol is it's a poison for the kidneys. But in which way this works? It works through crystals, please. And it works through because the ethylene glycol is processed in the body and the outcome is oxalate. So remember, calcium oxalates, calcium oxalate crystals, those are the ones that are formed and kill the tubules. And why I'm stressing calcium oxalate crystals, I'll tell you later, because they are also produced, or you don't have to ingest ethylene glycol, but also in some kind of diseases, it is made in your body. And oxalate is, of course, remember, calcium oxalate stones are the most common ones in humans, in the ureters, etc. So oxalate is normally produced in the body. But with the ethylene glycol, it multiplies several times how big production there is. So, and don't forget the last one, as always, non-steroidals. Very dangerous, and dangerous in a way because everyone uses them. That's why it is so common. And then you have endogenous, endogenous. I rather will not use the term endotoxin because that could be confusing. Endogenous toxins. Everyone knows that endotoxin, that's a toxin that is released from the bacteria when it is lysed. Okay, so that's not the case. We are talking about some substances that are produced in the body, and those are again crystals. Okay, and what else? Crystals. And what else? What crystals? Well, again, calcium oxalate. And remember one disease, remember Crohn's disease. When you resect ileum resection, there is a fat malabsorption. And when you have this combination of fat malabsorption, you will produce lots of oxalates in your body. So remember also, Crohn's disease leads to high levels of oxalate crystals, calcium oxalate crystals, and these kill your kidneys. It's not as fast and dangerous as with ethylene glycol, that's right away with ethylene glycol, but it can happen, okay? And still one more comment, as you are forming calcium oxalate crystals, remember sometimes in case studies tests, you can have a comment, small comment, and you should really pay attention for this. And this is that they will tell you you have a sudden hypocalcemia. And that's very typical, because if you drink ethylene glycol, you form the oxalate at the end, and this binds the calcium. So that's why you're having combination of crystals. And these crystals are consuming the calcium, so that's why you're having sudden hypocalcemia. So remember this. Those were crystals, but then you can have pigments. And by pigments, I mean hemoglobin and myoglobin. So hemoglobin, this is due to hemolysis. So in any kind of hemolysis, you can have high levels of hemoglobin, and it has 4 hemes. And this hemoglobin is very toxic to the tubules because it gets filtrated into the primary urine, and from over there it is resorbed by the epithelia, and it stays in the epithelia and kills it. It's a toxin for the epithelia. It's hemoglobin. And remember, it can be, any hemolysis. Let's say wrong blood transfusion. It could be mechanic hemolysis or whatever. But every time you're having hemolysis, think of kidneys. They can really die, or at least fail for a certain time. That could be intrarenal azotemia. The same account with myoglobin. And this is in case of rhabdomyolysis. So every time you destroy your muscles, and this is in crash syndrome, during marathon, or during trauma, etc. Every time there is a destruction of muscles, or also epilepsy. Okay, so marathon, epileptic seizure. When your muscles are teared down, they release myoglobin, and this myoglobin again gets into the epithelia of the tubules and kills them. So again, myoglobin, very dangerous. Not only this, in both of them, again, if you have lesions of the, and this is the first thing you should think of, don't forget there's hyperkalemia, so ECG, okay? This is in case of hemolysis and rhabdomyolysis, always think of hyperkalemia. And this is more important with respect to arrhythmia than to kidneys, okay? So myoglobin, and again, in case of rhabdomyolysis, remember, again, when your muscle cells are ruptured, they will also bind calcium. So you will have also hypocalcemia in this case. That's very typical. The calcium gets bound to the sarcoplasmatic reticulum, okay, which is exposed. So typically in rhabdomyolysis, they could also again talk about decreased levels of calcium. So those are pigments. Remember, hemoglobin, myoglobin. Another endogenous toxin is uric acid, which you know very well because of gout. But yes, it can happen in outbreaks of gout, very serious ones, or you can simulate a outbreak of gout, because what? Uric acid is a final degradation product of DNA. So every time you lyse cells massively, which happens after chemotherapy, for example, typically in cases of leukemia or high-grade non-Hodgkin's lymphomas, that's very typical. When you're trying to treat these diseases, you have what you call tumor lysis syndrome. So remember, it could be either gout, or we can simulate like serious gout, and that's called tumor lysis syndrome. Of course, in this case, you can deal with potassium as well and all the other stuff. But first of all, here is really high uric acid. So that's why that's in leukemia, if you treat leukemia or if you treat non-Hodgkin's lymphoma, and you kill lots of cells at one time, you're going to have hyperuricemia. And the crystals of the uric acids, which are again formed typically in the parenchyma of the kidneys, because they form in acidic environments, and kidneys are acidic because they're dealing with acids all the time. You're getting rid of acids through the kidneys. So that's why the crystals are formed there, and they're directly toxic to the kidney. So you can kill them with this. So either tumor lysis syndrome or gout, watch out. Also, that's why these crystals, they also form not only in acid environment, but in general in cold environment. And that's why, that's one of the explanations why the gout invades, or the crystals invade, small joints, because they are colder because they're more in periphery. So that's uric acid. And still with tumor lysis syndrome, remember again, potassium, okay, can be high. And then still we have hepatorenal syndrome. Hepatorenal syndrome means that the problem is not originally in the kidneys, but because you are failing with liver, you will fail with kidneys as well. So, or in this case, you're dealing first of all with the liver. And basically, there is not a clear explanation why this happens, but there are some, let's say, mediators or whatever that are released from kidneys. That's the theory. And what happens in the kidneys is pre-renal, or let's say what happens over there rather is sort of a pre-renal azotemia, although we put it into intrarenal causes. And what we know, there's a massive vasoconstriction of the afferent arteries. Okay, so that's one of the explanation, afferent arteries again. Okay, and don't forget, there is also a hepatolung syndrome, where also when the liver fail, then you have a fail of the lungs. Okay, so this is not as common, but hepatorenal is common. But the main thing you deal is, of course, are the liver. Okay, at this time. Well, that was hepatorenal, and still two more, and I will put it up over here. So please don't forget still atheroemboli. And the atheroemboli, this is due to endovascular procedures. And as you put the catheter into the aorta, and you touch the walls of the aorta, they are atherosclerotic plaques, and you strip them off. So crystals of cholesterol are released. They're very tiny, and they fly all around the body because it's an aorta. So some fly to the skin, and what you're having in the skin, it's called livedo reticularis. So you have blue skin, it's like marble in a way. That's one of the signs. And the other one, of course, this flies also to kidneys and kills them. So remember, during endovascular procedures, and this is pretty fast, like one day he goes for heart catheterization to the cath lab, and second day his kidneys are failing. And this is because of the atheroemboli. And last one out of these, and that's the interstitial one. So this one is special because most of them are, let's say, or all of them that I mentioned now, have to do with tubules primarily. But this one, this is the allergic interstitial nephritis. And the main problem over here is the allergy that is induced most commonly. It could be to viruses or bacteria, but this is to penicillin, for example, to some diuretics like sulfa diuretics, let's say sulfadrax, they're very common. But don't forget, not only that, but also, for example, allopurinol, which you use for, this is a bit funny, but you can get allergic to allopurinol that you use for gout. Okay? Or phenytoin, that's, you use it. Phenytoin is a anti-epileptic drug. So if you ingest this drug somehow, and this is very fast, this happens in 2 days, 1 day, or even like very fast, where you ingest this drug and you have allergic reaction that actually destroys or impacts the interstitium of the kidneys mainly. So remember, acute interstitial nephritis, that's the interstitium. We have it over here. That's the one I was talking about. So most of them, and typically if there is ischemia, you rather talk about acute tubular necrosis or its variants. And maybe we can talk about a variant of acute tubular necrosis. It could be some kind of the acute interstitial nephritis, and it looks a bit different, but it belongs over here. Okay? Yeah. So these all were causes: prerenal, postrenal, and now this huge group of intrarenal toxins. And mainly you should imagine hemoglobin, uric acid. You should imagine all those like really toxic drugs in general, okay? And don't forget maybe the atheroemboli, because more people every day are getting some kind of endovascular procedure. So always think of it that this could cause a acute kidney failure. So always think of hydration of the patients. They have to hydrate them, and in case, for example, there's a massive hemolysis, you hydrate them, and maybe you can give mannitol, and the idea is you're gonna increase the flow of the urine through the nephrons, and that's why you will decrease the time that the hemoglobin or myoglobin are like touching the tubules. So you will pee most of it out, and that's how you prevent the toxic effect of these pigments. And this same accounts with uric acid and everything. Very simple, you just flush it out. So always think of it. Good. Questions. So this was pretty big, but you have it on one slide. All causes of acute kidney injuries, most of them. You don't have the glomerular part.
Some question.
Yes.
So you said the intrarenal azotemia, it can be caused after the prerenal one. Like
I'm sorry. I'll tell you. Just we're in the next slide. So first, prerenal means there's a decreased perfusion of the kidneys. So that's why the kidneys, although they're feeling fine, they're not able to filter everything because the flow is so slow. So they just, it's like car wash or whatever. If the cars were gonna go too slow, you're not able to wash all of them in an hour. I don't know. Well, you get it. But because the flow is also very important to bring the oxygen and everything. So if the flow goes below a certain point, then the epithelial cells of the tubules will get ischemic and they will stop working because they don't have enough of ATP. So they will stop resorbing. Yeah.
Okay, and is the toxins like it has to be there in order for the intrarenal azotemia to happen? Like, is it?
No. Yeah, as I said, it can be only due to ischemia. If it's serious ischemia, you have it right away. But you can have a slight ischemia, then you're priming the kidneys. Someone can be dehydrated a bit, or be bleeding. He doesn't know. And now he gets one of the toxin, okay? So of
And
course this multiplies and they get a hit from both sides and they will fail. Okay. Yeah.
okay, and the post-renal, it can cause the intrarenal as well, isn't it?
Yeah,
If
yeah.
it were
Hey, example, let's say I'm getting rid of uric acid. No, I stop the flow, uric acid will stay there and kill. Yeah. So again, it always depends how serious it is, how the block, if it's anuria, total anuria, because there's a full blockage, it's going to happen faster. Of course, it depends on the time and severity. But they will fail then
and
intrarenal as well. Yeah?
maybe it's a stupid question, but the intrarenal azotemia by itself can happen without the prerenal
Yeah.
signal?
Toxin.
It can be.
Yeah, yeah.
Just toxin. Okay.
Well, you just drink ethylene glycol and the kidneys will die. Okay? Or contrast. Watch out, contrast is very fast. It's toxic for the tubules and also makes vasoconstriction, so combines the ischemia and it's very fast. And I'll give you more examples later, but always think of this. And as I told you, typically, this is important. All old people, their function of the kidneys is bad because we get old and that deteriorates with age. And their joints are bad as well. Well, okay, so it hurts over here, so I'm eating non-steroidals all the time. Well, and I'm just killing my kidneys, but I don't know about it. So always think of wisely what to prescribe them. And unfortunately, with non-steroidals, you don't have to prescribe them. So that's why they are so dangerous. Everyone uses it all the time, and they don't know that they're killing their kidneys slowly. But if they take a too big dose for a few days, it's very fast. Okay? Good. So,
I'm sorry, Ota, I have a question as well.
yeah, good.
Regarding the endogenous toxins. You mentioned about gout disease and uric acid, and somehow it was connected to tumor lysis syndrome.
Yeah,
And I
yeah.
didn't get the
Yeah.
connection. Why?
Because uric acid is the end product of if you destroy your nuclei with the DNA. And gout is high levels of uric acid that are floating in your body. That's a, let's say, metabolic problem. And if there is a high level continuously, it will form crystals in joints and it hurts. You suddenly have gout. But typically it goes slowly and it's not serious. But you can have some serious outbreak and then you will have crystals in kidneys as well and you kill your kidneys. With tumor lysis syndrome, you just, you're giving someone cytostatics. So you're killing all the cells, you destroy them, and you have burst of uric acid. So you don't have to have gout, but you have a sort of a tumor lysis syndrome gout.
Yeah, I understand it now. Yeah.
So,
Great,
so
thanks.
I'm sorry, I also have a question.
yeah.
About the treatment of the intrarenal, it's also hydration?
I'm sorry?
The treatment of the intrarenal, it's hydration?
Well, it depends. In many of the toxin, there's no treatment. You just wait and you pray that they will regenerate. That's the big deal. With prerenal and postrenal, you can save the kidneys, but once they turn into intrinsic, in most of the cases, there is basically no treatment. Like, you won't stop the process. You just pray that they will regenerate the kidneys, okay? So it's very hard. We would have to be specific, but in most of the cases, you cannot do anything. When it turns intrarenal, you just have to wait. You save the patient by dialysis. He won't die because you're monitoring the potassium. And you pray that they will regenerate. In most of the cases, they will regenerate. And I'll tell you this about the phases of the acute tubular necrosis. But some cases are dead end. Like ethylene glycol, so it depends how serious it is, how much of the toxin you ingested.
Is it like the, how's it called? The oligouric phase and all
Yeah, we'll get to it, exactly. But now, as I said, first I'll tell you the causes. And the important thing is also that you understand it's not like, again, black and white with acute tubular necrosis. I'll come to it just right now. So enough of questions. Let's get to last 3 slides. Okay, and there's gonna be a lot of it still. So, thanks for watching, and don't forget to subscribe and ring that bell. And as always, check the description below for supplementary questions and other materials.